For everybody's time, it's 12:05.
Sure. Who else are we waiting for?
Oh, so
Yep.
she's sending us down.
She just joined.
Okay. Did we lose someone?
No. Hi,
I
Sankuta.
think we lost the list.
Hello.
Oh, Sequenza. Just lost the list. Okay, and she's back. So good afternoon, everyone. My name is Marquita Idarisu, QI Specialist at the DC Primary Care Association. This meeting is being recorded. I will be co-facilitating today's learning collaborative with my partner, Michelle Tropper. She is the Director of Clinical Programs at Health Efficient. Before we get started, I have a few ground rules for today. Today's learning collaborative is meant to be very interactive. I know we're a small group. That just means we have to speak more. So I'm going to ask everyone, to the extent that's possible, to turn on your camera so that this will allow us all to be able to better react to the subject matters that will be discussed. And I also wanted to reiterate, there are no right or wrong answers. We hope that in this session, we will have the space to learn from each other and come up with solutions that work best for your respective practices. Now, before I go over the agenda, I just want to remind you that this learning collaborative is a debrief of the meeting, the Qual IT meeting that took place 1 week ago today. And that's where we had Dr. Dorado Brooks from Exact Sciences and Mr. Ben Lindell from Exact Sciences share with us 2 presentations. Dr. Brooks shared with us about colorectal cancer screening communication strategies and colorectal cancer screening guidelines. And Mr. Lindell from Exact Sciences shared with us about various HL7 interfaces for ordering Cologuard in the EMR. I'm going to take this moment to share my screen. So you can see here, we'll start with some introductions. Again, my name is Marquita Idarisu, QI Specialist at the DC Primary Care Association. I'll let my colleague Saba introduce herself, and then we'll allow for Health Efficient, and then we'll have MedStar, and then we'll have Unity to introduce themselves.
Good afternoon, everyone. My name is Saba Sumo, and I'm the Quality Improvement Program Assistant working with Marquita at DCPCA.
And I'm Michelle Tropper. I'm the Director of Clinical Programs at Health Efficient. Health Efficient is a health center control network. It's a partnership between Health Efficient and the DC Primary Care Association and the Mid-Atlantic Community Healthcare Association. So we have members all across the East Coast, primarily in DC and Maryland and New York. We also have members in New Jersey, Connecticut, Florida, Pennsylvania, Louisiana, Kentucky. And we just put in our application for our next round of our HCCN. And with that new application, we are adding 9 more health centers in the Pacific Islands from the Pacific Island PCA. So we're adding a new partner. We're really excited to be here joining with Marquita and Saba from DCPCA and Sankuta from the DC Department of Health. We are working in collaboration with both DC Health and DCPCA on this initiative. We have expertise that we bring to this project in terms of looking at workflow assessment and helping you identify how best to implement the evidence-based interventions that you've selected for your various initiatives. And through our health center control network that DCPCA participates in, and Unity, I know there's a few folks from Unity here. Your health center is part of our network as well. So in that network, we offer our clinical quality improvement work group. We were happy to open it up for the other partners in this initiative, including MedStar. I'm not seeing any other partners on the call today, but yeah, we're happy to offer those work group discussions when the topics are relevant for these screening initiatives. So really happy to be here joining with Marquita and Sankuta and Seba and the rest of you for a dialogue around, we didn't have time for it at our call last week. So we're gonna have those discussions today in a smaller group setting and making it relevant to the work that you're doing for this learning collaborative. I'll turn it back to, is Sankuta next or Marquita? Yes. Okay.
We'll have Sankuta and DC Department of Health, anybody from that team introduce themselves, and then we'll have MedStar.
Thank you, Marquita. My name is Sankuta Riverson. I am the colorectal cancer program coordinator at DC Health, and I'm really excited to see all our partners from DC3C joining us here. And this is Learning Collaborative number 2. So I'm so thankful for Marquita and Michelle and all the work that you guys do in facilitating these discussions. So thank you.
Thank you.
I think I'm going to go next. Hi, everybody. I'm Jennifer Tran. I work at MedStar Washington Hospital Center. I've had the privilege of having support of Sankuta at DC Health, of working with Michelle to improve our workflow processes, and with Marquita and her great collaborative support groups. We service about 10,000 patients a year at Washington Hospital Center. And I think that with everybody's help, we're working on improving our colorectal cancer screening rates. So thank you, everybody. I'm really excited to be here. I also have a colleague, Patricia Chajugo, who may come later. She's running in between meetings, so she might pop in later.
Thank you. Now we'll just have the Unity staff introduce themselves.
All right. Hi, everyone. I'm Hannah George. I'm in the office today. Woohoo! It's our third week back. My camera doesn't work on my desktop, so I wanted you guys to see me, but good to see all of you. I'm Hannah George, Director of QI for Unity Healthcare, and it looks like I have some of my lovely colleagues here, so I'll pass it on.
Hi, I'm Rona Schwartz, and I am the physician lead for the cancer screening QI working group at Unity Healthcare.
Hi, I'm Celeste G. I'm the chronic care program manager at Unity Healthcare.
Thank you, everyone, for those wonderful introductions. So now I'll talk a little bit about let me just go over the agenda, and then we'll get back to the objectives. After the introductions with which we just completed, we'll go over the objectives, and then I will facilitate a discussion about colorectal cancer screening guidelines and the importance of options. And then we're going to hear from Dr. Schwartz. She's going to give an update on some of Unity Healthcare's Cologuard pilot study, and she's going to share some of the information about some of the work that is in partnership with Washington Hospital Center. Down just a little bit. And after Dr. Schwartz, we're going to have Michelle to share some, to facilitate a discussion around colorectal cancer evidence-based interventions. And then I've just been made aware that DC Health has to leave the call a little bit early today, and so I will just hop in and share announcements and information about future training. So our objectives or goals for today's session are for, by the end of the session, you'll be able to walk away with the understanding about the importance of offering colorectal cancer screening options to your patients. And number two, identify colorectal cancer EGIs and challenges program implementation. So if you have anything that you can walk away with from today, those are the two things that we hope you have a better understanding. So hopping right into things, Seba, can you cue the poll? We have a poll question that we'd like for you to participate in. So our question is, which CRC options do you or your practice recommend to your patients? You could just take some time to answer that poll. Okay, so it looks like Cologuard, FIT, colonoscopies are the preferred screening tools. That's good to know. We always like to kind of know what health centers and hospital centers are offering to patients. Some of the ones not selected are also recommended, but I know there are various factors that come into play into which ones that may be selected or not. And that kind of brings me into my next question, which is, how do you communicate?
Sorry.
That brings me to my next question, which is, how do you communicate with patients about options for colorectal cancer screening? So I'd like for you all to come off mute and let's have a lively discussion about how we communicate with patients about options.
So, hi, Jennifer Tran again. So I always, when I speak to my patients, if they're not up to date on screening, I'll always tell them about the importance of screening before I go into options, just to make sure that they agree to pursue screening first. And then I'll usually say, you know, traditionally we used to offer the colonoscopy for screening, but now there's options to screening. There's the stool-based home test kits, and then there's still colonoscopy. And then I'll go about the risks and benefits of both. Because I think, you know, having the patient make an informed decision about the risks of doing both is important too, because if they don't want to pursue a colonoscopy, but they want to do a FIT test or a Cologuard test, it's important for them to know that if it's positive, I mean, they really are recommended to pursue that. And they should know that going into the to doing a FIT kit.
I agree, you know, similar. And I think during the last couple of years, you know, the uptake for FIT tests and Cologuard has been stronger because of patients, you know, being fearful about going to hospitals, and also a little bit of backlog and getting colonoscopy.
Yeah.
You know, for the primary care doctor, it is a matter of time, right? We have, like, you know, small amount of time with the patient. So sometimes, you know, I have to admit that I am very quick in the explanation, and sometimes I'm much longer. You know, sometimes I say, you have different options, you know, other times I really take the time to go through it. But, you know, sometimes when you're rushed, you kind of feel out the patient quickly and sort of see which way they're leaning and go for it. So, you know, at Unity, we have a pretty good uptake for stool-based tests. And it could be if we had more time and more chance to educate patients, that wouldn't be the case. I don't know.
Mm-hmm.
I'm wondering if you have any other staff that might be available, you know, after you do like an initial recommendation to provide more details. Is that something maybe you've looked at or might consider, you know, to help with the timing issue?
Yeah, we were talking about, you know, our waiting room has, some of the waiting rooms at Unity have these videos that play. So we've been talking about getting it on the videos. And MedStar, Marjorie gave me this great packet of these handouts that has the MedStar logo, but it has the different options. So using that was distributed to a bunch of the sites that shows sort of the different testing. Yep, thank you.
Oh, that's great.
Yeah, we
And
were.
I know when we, go ahead.
Dr. Schwartz, I'm sorry, and she's been fantastic. She creates these handouts, and on the back, you know, they talk about the different options. And then if patients are really kind of hesitant, but you know, you do think they need screening, she's always willing to help navigate them too, and also just talk to them a little bit. I have patients that are a little bit hesitant, and she's always a resource that we utilize as well.
I think, I mean, to be honest, one of the is we have a lot of things to talk about with the patient. You know, the colon cancer screening is one of them, as a primary care doctor, one of the many things that we have to talk about with patients. So if it was only talking about colon cancer, that would be that's a little bit hard. I think, you know, even with the rest of the staff, but that is a good point that we probably could use staff better to talk about that.
Now, and I have a question around like outreach. Do either one of your organizations do any outreach before the patient comes into the clinic or office? And if you could just talk a little bit more about some of those outreach strategies used to communicate maybe those options to patients.
I mean, Unity has tried different things. At one point, they did like a robo text to everyone. This was when the guidelines were 50 on their 50th birthday. Each site individually has done some projects where they run lists of people who are due, reach out to them, or for people who've done a fit test at 11 months, they have called them, but it's not something that is a standard. They've been sort of different things that we have tried. There are some providers who work with their team on a QI project, and they'll reach out to everyone due and set up a telemedicine appointment with a provider just to talk about colon cancer screening, which has been successful. But there's not like a standard thing that we do.
Yeah, I want to also echo Dr. Schwartz. We, prior to starting our colorectal cancer improvement screening initiative with Zenkuda, we did not have anything in place to really do patient outreach. It was at their visit. But since we started this project, we do have Patricia, I wish she was here today. She's been calling patients ahead of their visit a day or two to just really counsel them on the importance of screening, and not necessarily to offer options, but just to inform patients that, hey, you have an upcoming visit, you're due for screening based on your records. You know, it's important to get screened. Talk to your doctor about it. You know, if you have questions about why you need to get screened, she provides a little bit of information about that. But that's been a good resource as well. We're working to transition that to a text-based method just because of the labor-intensive work it is, and you know, having a large volume of patients to call, so that patients would receive a text message, you know, a day or two prior to their appointment to remind them of the importance of screening and that they're due for screening as well.
Along those same lines, I'm wondering, has anyone ever thought about using medical assistants to perhaps do some type of standing order for some type of screening, such as fit tests?
So
maybe
Unity does.
Triage. Go ahead.
Unity does have a standing order for fit tests.
Okay.
So, but that's for people in the clinic, right, who are due, or people who so if they're in the clinic, there's a standing order to give them one for the medical assistant. But the outreach to people who are not in the clinic is not done consistently. It's only done when you know, a team is working on that as a project.
Okay. I'm sure when we get a little bit into the meat of this project, and as the months come, we can talk about how we can make things more consistent across the practice. Dr. Tran, did you have anything? And Celeste and Hannah, feel free to chime in on the conversation. Sorry for monopolizing it.
Sorry, Celeste and Hannah, if you want to go ahead and jump
on. No problem.
Mm-hmm.
I'm more so here as a learning opportunity,
Sure.
just to understand more so what can be done and what recommendations you do have. But Dr. Rona is the expert on this, so I will chime in if I can.
Sure, sure. And I echo what she just said, Celeste. I think we met earlier this week or last week, Celeste and I, and we figured that we'll come here and just learn. We're really here to participate. I'm actively listening and actually taking notes. So we will always refer back to Dr. Rona Schwartz as our, content expert in this field, and as we grow and learn from other organizations as well. So happy to be listening. And, once I feel the need to ask questions or chime in, I surely will.
Sure. Okay.
All right. Bye-bye.
Dr. Trent, I think you had you wanted to finish your thought.
Yeah, I was just gonna say, in our clinic, I don't know if you have the same issue as Unity, but we are always chronically short-staffed, particularly of medical assistants. So sometimes even getting patients broomed and triaged and getting their vital signs is difficult. Like I'll end up doing that sometimes because we're so short-staffed. So adding an additional task for them is difficult sometimes. So we don't have a standing orders in place like you have at Unity, but I think that's something we're working to develop. And if I could ask some more questions about how you actually have that set up, so that I could get an idea or framework of how it may work in our practice. Do you order your next year fit test at the same time you order your fit test, and so it's a recurring order, or do you wait for the results and then you'll order from there?
I think the standing order says that the MA can actually put in the order under the doctor's name. So it's the MA who orders it, but they're doing it. That is a great idea to put it a year in advance. I didn't think of that. But so basically, we use Azara, which is a quality tracking software that pulls from our EMR and gives us lists. So, one of two things happen. Either there's pre-visit planning. So my MA goes into Zara, prints all the patients coming in today, and it shows what people are due for what. And so when she sees that my 10 o'clock is, due for fit test, she has it all ready and labeled, and she can put the order in, or I can put the order in. That I think we have a pretty good system. For the people who are in the clinic, we have a pretty good system. It's the people who we aren't seeing that we really have a hit or miss system. For the people who aren't here, it's if someone's working on a project and reaching out. The other day, we had a provider out, so an MA had time, so they went and pulled a list of people due for fit tests and started calling them. But that's not a regular thing. The regular thing is the patient in front of you, getting them screened. You would think our rate would be like 100%, right? Because we're supposed to, every time we see someone, go into Azara, see what they're due for, mammogram, fit testing, colonoscopy, and if the patient is due for fit, the MA can give it. If the patient is due for colonoscopy, the MA doesn't do anything and leaves it for the provider to initiate.
So I have a follow-up question. Do the MAs ask certain questions before offering the fit? Because I know the fit is not for patients that are that show symptoms or have like a strong family history. So is there some assessment before that takes place?
There is. They came up with a training where the MA is, supposed to ask some basic questions. You have family history. Are you having any GI symptoms? But in general, what I find most of the MAs are most comfortable doing is giving a fit to someone who did a fit before. And they probably ask a little bit, but not a lot. Most MAs don't give a fit to someone who's never been screened before because they maybe feel like maybe there's some reason, So at minimum, they do it.
So that might be something in the future that we could possibly work with Unity on, just making sure all MAs are doing it consistent across the board.
I think when we had a slide before about asking the MA to ask about family history of polyps, the MAs were a little bit overwhelmed. They felt like, well, that's a lot of questions, we kind of thought there's probably no danger if they gave a fit test and then the doctor went in and talked to the patient more and said, okay, actually this patient needs a colonoscopy. Let me toss that fit test, right? It's like, so probably they err on the side of giving them to some people who don't need them, who would do better for a colonoscopy. I think that's probably what happens.
That's great. I'm going to move on to our next question. And I feel like I might know the answer to this, but I'm still going to ask it. I know, at least for in COVID times, there was a preference for patients to do the stool-based testing option. But just in general, do your patients prefer one test over another test?
I think we still are in COVID times, even though it's better. A lot of patients still haven't really come back to the practice. Like some of them still really want to do telehealth, or they're like, I really don't want to be in the hospital for a colonoscopy. So those patients almost always prefer a stool-based test kit instead, just based on my experience. But other than that, it's really either or for me.
When I was a patient navigator, I remember a patient actually preferring the colonoscopy over the fit because they felt like even though it was invasive, you get a chance to see a polyp. And they actually had I forget the word that you used, but there was an ick factor associated with collecting stool. And so that was one situation where I noticed someone prefer a colonoscopy over another.
Yeah, I think there are definitely patients who prefer colonoscopy, especially if they have read up on it and they, like you said, like the idea of having, every 10 years, not having to touch their stool. It's interesting. Someone asked me the other day, they said, oh, you work at a community health center. Do your patients request colon cancer screening? They were saying in the private practice world, patients go to their doctor with that as the reason of the visit. And it is true. Very few of my patients come to me saying, I want to be screened for colon cancer. Maybe, after Chadwick Boseman died or something like that. But in general, it's pretty infrequent that my patients bring that up. It's usually me saying, hey, it's time. So I'm not sure why that is, why. And
do you think there can be some like education and literacy around that in general?
Yeah, definitely. I think, the social media, marketing, all those kind of things, just bring it to people's mind, right? So
I'm wondering, I know we're talking, this session is about colorectal cancer, but do you notice the same thing when it comes to like breast cancer? Do they come in asking for a mammogram? Do you get a little bit more proactiveness from patients when it comes to that versus colorectal? Maybe the people in that sphere have like honed in on something.
Yes, I do think more women do ask for it.
Yeah, it's the same in my experience too. It's, women will come in because they're like, oh, I know that I have to get a mammogram. But and same in our practice, not a lot of people actually come to me and say, I need to get colorectal cancer screening. So I think this also has to do with the health disparities that DC faces, right? In the communities that we service, they typically are the communities that are underscreened, right? And so that's why this work is so important for us to collaborate and help to improve those disparities.
I'm just interested, sorry, Dr. Schwartz and Dr. Tran, do you think it's more so tied to stigma and taboo with colorectal screenings, or what may seem to be the biggest hindrance besides lack of knowledge? Just maybe some behavioral aspect may be triggering that as well.
I think it's a really good question, and I don't know if we truly have the answer because everyone's a little bit different too, right? For some people, they're just, I didn't know I needed colorectal cancer screening. No one's ever told me, and I'm 70. And there's some people that are like, they think colonoscopy is the only option, and they're like, no one's touching my bum, or I'm not taking that prep. And some patients are just like, I don't want to find out anything, so I don't want to get screened. So I've had, like a mix of all three, and I'm sure there's Dr. Schwartz probably has a whole bunch of other, different types of reasons as well.
Yeah, I think definitely, health literacy is lower. I think you don't see your colon, right? Where your breasts you kind of, you know, like I think it's a part of your body
Yeah.
we just don't know much about how things work in there, you know. And there definitely probably are some cultural taboos. I'm not, patients don't bring that up to me. I don't know, but.
You know,
I'm tapping back into another experience as a patient navigator. I remember a time I had received a referral from the provider, and I was on my way to get the patient scheduled. And the patient, this was a male patient that I was working with, and it just so happened that his significant other was with him while we were working the referral, and this is pre-COVID. And when I was explaining the process about, at this time, the provider had wanted the patient to have a colonoscopy, not a fit, the significant other hopped into the conversation and was just like, no, nothing is going up in the spouse's bottom area. And there was this stigma associated as if, because I think he had just recently left prison, that this was like a check to see if maybe he didn't necessarily identify as heterosexual. And this was a female significant other. And so she took a little bit offense to that. And that was the opportunity for me to provide education to say, no, this isn't necessarily checking to make sure this isn't about sexuality at all, basically. So I know we started late and I'm really bummed, but I want to add one thing before I move on to Dr. Rona Schwartz, because I really am interested in hearing what she has to say. But as all of us on the call know, the colorectal cancer screening guidelines have changed, and 45 is a new age that colorectal cancer screening should be offered to patients. And even though the UDS guidelines, when I think from the clinic perspective, hasn't completely changed just yet, that is something that health centers should definitely be thinking about how to implement if they haven't already. If your doctors aren't already and providers aren't already doing that, go ahead and get on top of that, because that is going to be coming down the pipe soon. And you want your numbers to be able to reflect that. From the hospital setting, Dr. Tran, have you already started to make that shift?
Yeah, so
Okay.
glad that you asked, actually. Because of this project, we actually got them to change it MedStar system wide so that the screening pop-up starts at 45 instead of 50. So
Okay.
that months ago.
Gotta love the pop-up reminders in the EMR. Okay, Dr. Rona Schwartz, I have your slides. If you want me to, I can share my screen, or you can feel free to share your screen.
Yeah,
Just
go
let
ahead.
me
And
know.
if you can share it, that'd be great.
Okay.
Yeah, it's interesting. So we updated our EMR to remind you at 45, but Azara, which we do the tracking, we have not yet updated, because Azara is how we report to UDS. So
Okay.
I wonder.
Actually, our pop-up starts at 45, but to get the reports, it starts at age 50, and we can't seem to get them to change it either. I don't know why.
It's almost like we would need two different reports, like one for our own quality improvement and then one for reporting, one at 45 and one at 50. I don't know. Okay, so Marquita asked me just to speak a little bit about this Cologuard donation kit. It's a partnership between the Colorectal Cancer Alliance and the company that makes the Cologuard, Exact Science, and their goal was basically to improve colorectal cancer screening rates in underserved patients. And they were targeting patients at the time who could not get a Cologuard otherwise. So at the time, Cologuard was not covered by DC Medicaid. It was only covered by private insurance or Medicare. So we were targeting patients 45 to 64 who were uninsured or on any of the DC Medicaid or Alliance. And we worked with Exact Science to come up with a system. We developed a workflow in our EMR, like where we send a dummy referral called Cologuard to our care coordinator. The care coordinator has a login to the Exact Science portal and orders the Cologuard. We started recruiting a small number of providers who were interested in participating, only because we figured there'd be a lot of errors in the beginning, which there were. I think we have about 18 different providers at this point who have gone in and ordered it. Next slide. Okay, so the Colorectal Cancer Alliance, who is, I guess, paying for the Cologuards or with the donation from Exact Sciences. So far, 190 orders. So they have shipped out as of 185 shipments. They got 55 of them. Interesting enough, and this is one of our barriers, is of the 55 kits that Exact Science got, 43 were successful returns, meaning the other ones had errors and were not able to be processed. And the reason why, many of them, if you see on the bottom right, were expired samples. Patients didn't do it right. The Cologuard is a complicated, I have a sample box they mailed to me. It's complicated. A patient has to take like an entire large sample, put it in the kit, open up a liquid, pour it on, seal it, and they have to call UPS, and it has to get to the Exact Sciences lab within 72 hours. And if it doesn't, it can't be processed. So this is where we stand on how we're doing so far. Go ahead to the next slide. So challenges. So the bottom challenge, which I mentioned before, is the high rate of incomplete specimens. We're looking this a little bit. One of the providers who works at the East of the River Clinic is the one who has the most incomplete specimens. So we're wondering, is there some part of town in DC that UPS is slow to pick up? You know, is that something to do that the patient has a sample ready but calls for UPS and they don't come? I don't know. The other challenge is our EMR. So we had to make this entire workaround. Our EMR does not communicate with Exact Science, with the Cologuard company. So we make a referral, the referral goes to care coordinator, they make a password, they log into Exact Science, they order it, they check it back. So we have, you know, turned something that could be like one step in the EMR of like ordering a fit versus, you know, 6 or 7 steps. And then the other big challenge is Unity decided they wanted all of the Unity care coordinators trained. So there's 30+ care coordinators at Unity, and some work in GYN and some work in homeless, but all of them were trained on this portal, which was a little bit overwhelming because some of them had no idea what colon cancer was, and they have a high turnover in these positions. So those have been the challenges. Next slide. So takeaway so far is that patients have been surprisingly receptive about doing Cologuard. You know, we're a little nervous compared to people who have done FIT before, that maybe having a large stool, mailing it would be intimidating, but they've been very receptive. One thing I wish we had done is had like one central employee at Unity who did all the portal ordering, because I think that would make it a little better. Instead, we have like 30 people who are constantly telling me I forgot my password, I can't log in, you know. And then of course, big one would be EMR integration. And another plus is the Cologuard has worked really well for telemedicine. One of the sites did a QI project where one of the providers who was doing telemedicine from home reached out to her patients due for screening. And like within a month, she had mailed out 50 Cologuard kits to patients. So anecdotally, there was one patient who, I forgot what the word is, but was like on home arrest and couldn't leave their house. So like a Cologuard was a great test for that patient. And then the only problem with the donation program is we're not billing the patient's insurance, even the ones who have Medicaid. So the insurances aren't able to know that the patient had colon cancer screening. So that is the other problem with the program. And the other problem, of course, is now we know that Medicaid does cover it. So we're about to see how we can transition this program.
Yes, and Rona or Dr. Schwartz and I have a meeting with the folks at Colorectal Cancer Alliance on this upcoming Monday. So to be determined. Michelle, I saw you come off of mute, so I'm anxious to hear your question.
So I think this is like really interesting learnings that you have from this initiative, and you know, it's great to see how you've outlined all the different challenges, the takeaways. Particularly intrigued by this particular slide with the you know, the 190 orders, 185 shipments. 55 kits received. So the 130 that didn't send back a sample, have you done any interviews with those patients or learned from what the issues were with them?
We haven't yet. You see on the curve from the number of orders, like, or we started ordering in December, like the biggest chunk of orders have been literally this last month. We went from 62 orders in February to like 100. So I think we're right at the point now where we're, going to start getting more feedback. The care coordinators are supposed to go back and check in the portal after a couple of weeks and see where the results are. It's interesting because one of the things we thought would be good about this is Cologuard told us that for 30 days, they nudge the patient, that their policy is they call the patient, they text them. So
they have an internal patient navigation system.
Yes. So, I was kind of hoping that doing a Cologuard would take the burden off of us and that the company would take over. And that I'm not sure what's going on. So I don't know yet. I'm hoping that pretty soon we'll get some more feedback on that.
Yeah, it'd be interesting if do you have a dedicated person from Exact Sciences that's following up or?
Yeah, so they don't want their company to know that these people are getting it for free or whatever. So, they do the same protocol they do for all their patients. So supposedly, for 30 days, they hound the patients about it. So, some of these people are still within their 30-day window. So maybe the Cologuard is calling them right now. I don't know. Maybe we gave the wrong number. Maybe. Yeah. I don't know. I mean, Cologuard
it would be definitely good to kind of check in when we check in with Colorectal Cancer Alliance on Monday to kind of share with them some of this feedback for sure.
Yeah.
So the initial, I'm having trouble seeing. So the first date there was, you said December. I can't really see what the timeline is on the order.
Like basically, the orders really, January was like 23, February 62, in March 100. So we really, it's the last month that we really started doing a lot more. So you would think the 30 days is right about now for the, for the last 40 or 50. So hopefully those are coming in.
And hopefully they were doing
one thing I want to mention. Okay.
Sorry, hopefully they were doing the follow-up with those 20 patients who got their kits in February and didn't wait to start following up with them until March.
No, the company told us they have a protocol for the 30 days after they're sure the patient gets the kit, they start doing a certain number of calls or something. I think after 30 days, I think they may stop. I think they try for 30 days.
All right, so it might be some of those. Oh, I'm sorry, Marquita. It might be some of those that went out in February, went out later in the month, right? And that we're right at the 30 days now for the February. And maybe you'll see more completions next month when all those that went out in March start sending them back and completing. So you kind of have that 1 month lag time. Yeah, okay, sorry, Marquita.
That's okay. I was going to mention that another one of the objectives of this project was to see if how does Cologuard work within an SQHC setting? In a setting like Dr. Tran's, a hospital where you see more than just a significant Medicaid population, where you have a range of different insurances, perhaps that population might take the Cologuard a little bit more when it comes to the shipment, or maybe the addresses where they live, to Dr. Schwartz's point, is different from the shipment where some of the SQHC residents live. So this is a good pilot because Unity is the largest SQHC in the city, and the information that is coming from this study can kind of like inform some of the work that's happening in other SQHCs, some of the lessons that we learned. And also I'm thinking now that Cologuard is accepted by the MCOs, this is information they would like to know because, a good return on investment is always important. Dr. Tran, do you work with Cologuard? And oh gosh, I just saw that it is 12:50, and Michelle, we have like a whole section we did not get to.
It's okay. We are having such great discussion here. We could always
so
pick up
sorry.
the other discussion at another time. It's really
Okay.
great. I think the information that was shared earlier on the guidelines and Dr. Schwartz's presentation, this is, we have such a meaty agenda to cover today.
Okay. Okay. Well, I want to hear from Dr. Tran now about her Cologuard experience.
I'm going to be honest, it's very similar because we do service a lot of Medicaid patients too. I would say
Sure. Okay.
half of our patients are much more than half probably are Medicaid, Medicare. We also have a return rate in like the 30-something%. I was talking to the Cologuard representative. We do order Cologuard quite a bit as well. And he showed me a way that I could track all my outstanding orders actually for everybody in my practice. So I don't know, Dr. Schwartz, if you've been shown that. I didn't know I could do that before, so I could show you how to do that on the Epicare link. But it looks like, I'm actually looking at it right now. A lot of times it says kits delivered, but it says that for a while and I don't know. So maybe the kit's delivered and the patient just hasn't done it yet.
Oh, okay.
That's just what I'm seeing based on last month's data though.
Yeah, I also can look at all of Unity and it's a lot of kits delivered, but you're probably, I think in general, I'm sure a lot of people, I know of a friend who got a Cologuard kit and never did it. I'm saying I'd be interesting. I wouldn't be surprised if the national rates of return are not 100% for Cologuard, but I don't know what they are.
Yeah, I think people need to be ready to do the test, regardless of what type of test it is. I had a pile of orders on my desk at home for my husband for his colonoscopy for 5 years. He finally went and had it done in the fall. So yeah, I was very happy about that, but it took 5 years and, I'm a big advocate for colorectal cancer screening. He just wasn't ready. So yeah. We almost got him to do the Cologuard test. Between the doctor and I, we were like talking about how best to get him tested. And he just agreed to. I'm like, even if you do Cologuard, if there's anything showing up, you're gonna have to go for a colonoscopy. Wouldn't you rather just do that? So I think that's probably one of the biggest challenges. And then the disparities issues that you were talking about are really striking. It would be interesting to hear if there are any issues from UPS and that if you can intervene on that, because they're really disrupting the cycle. Those kits do have an expiration date, and if UPS won't deliver, then you got to find another carrier that will.
And during COVID, a lot of patients received medication through the mail. I wonder if these same patients experienced challenges with other medical necessities that they needed.
Yeah, that does bring up, because we've always wondered about patients' addresses, and not every apartment has ability to have a UPS pickup. And so I don't know if the providers, when they're offering the Cologuard, are they saying, do you live somewhere where you can get packages,
Well, I know we're rounding out our time together. I wish Sekunta was on the call, because I just want to share one of the topics that we're looking at in the future as it relates to ECW integration. That's something that DC Health and DCPCA have some preliminary conversations around for the upcoming fiscal year. And ECW is what the health center uses, Unity uses. Dr. Tran, again, I can't recall what EHR you use, but I'm sure once we continue to flesh out these preliminary conversations, there may be opportunities to also talk about how we can integrate it into your system as well. And so, there are other things to consider as such. Like Brian Liddell mentioned in the presentation, there is a cost associated, significant. I think at one point he quoted maybe like a $25,000. We have been quoted something differently. So we're going to have to work with Jim Costello and our team and Michelle to make sure that we are all on the same page with this, and see if anything, maybe even just kind of pilot one Unity, you know, to see how this integration between Cologuard works, because we don't want this to be a taxing service for the providers and the care coordinators, you know, to have it in a one-stop shop kind of thing, kind of addresses one of the challenges that you mentioned. So that is to be determined, and we look forward to hopefully having some good news to share on that front.
Yeah, and I do know that we put Ben Lindell in touch with Dory from Suncoast, who is one of our members in the HCCN. She's the one who suggested the direct messaging portal as a way.
With the P2P.
With a peer-to-peer, yeah, P2P. So I know they've already been in contact with each other, exchanging messages about how that might work. Any clinical works. I know with Epic, they mentioned there's an HL7 interface there too. It sounded like you might be working with the portal in Epic already, but you know, we could definitely have more conversations about that, and also, you know, separately with each practice as we work with you individually.
So on that note, I want to say that in closing, we do know that there are a few meetings that are left to be had before the end of this fiscal year. There is a STEPS guide training that Michelle will present to you, and hopefully other members of your respective organizations will be able to join the meeting. The meeting is going to be determined either in May or June.
Right.
Michelle and I will get back with you on that date. And then if you could kind of just pencil in the third Learning Collaborative meeting, we're looking at it to be June 16th, and more or less it'll feel and look like the meeting that we had today. And we're looking at getting a FQHC on the agenda who has reached the 80% mark and or is close to it. So that is, we're hoping that we can learn from some best practices from them at the next Learning Collaborative. So that just gives you a little taste of what's to come. And on that note, I will drop this link. I'll give you the link to the evaluation. If you wouldn't complete that, we would really appreciate that. I'm dropping it in the chat now. And Michelle, did you have any closing words before we end?
Yeah, can I make a pitch for our conference? So you're all invited.
Yes, please.
To attend our conference in April. It's April 11th and 12th in Baltimore, Maryland at the Inner Harbor. And I'll give you a link to that RSVP. Let me just quickly bring it up on my screen. Let's see. Just have to bring up that's the wrong one. Quality screen. Okay.
While Michelle is doing that, I just want to thank every single one of you on the call. This conversation, this discussion was very fruitful and very helpful, and it's going to definitely just inform the future year's work.
Yeah, so I just dropped the link to our registration page for our conference, and we have great sessions planned. It's not specific to colon cancer screening. So the theme is coming together, a path to equity and resilience. And we have topics on achieving hypertension, or achieving equity in hypertension outcomes. So that's our keynote speaker on the first day. We have someone coming from the ARC Center talking about transcendental meditation and using that to build resilience, how, and the evidence base behind it. We have a speaker on the second day from University of Maryland, who's going to talk about unconscious bias in healthcare, and that will be followed by a panel of a couple of our CMOs from our member health centers, moderated discussion. We have an advanced data analytics breakout session where we'll be talking about the different advanced data analytics tools and using data to improve quality. And we also have a panel discussion around a multi-stakeholder approach to diabetes quality improvement. So those are just a few of the clinical sessions. I highlighted the clinical ones because I know you're all clinical, but we also have topics in HIT and also in health center operations. So it'll be great to meet you all in person. Hope you can make it. And it's local for you. So, hopefully it works with your schedules. Thanks.
All right. I see Dr. Chapman has signed up to go to that conference. So a plug for her.
Yay.
But we would love to have you have more people.
Yeah.
Okay. Thank you so much.
Thanks.
Bye-bye.
Thank you.
Thank you. Bye.